how to interpret, read our stroboscopy and the various drawbacks. We have often come across these kind of images. This is nothing but strobe effect. Stroboscope was invented by Simon Ritter von Stamfer and who also coined the term stroboscope. Instrument which is used to make a cyclically moving object to be slow moving or stationary. The principle is based on Talbot's law and flicker-free perception of light. You can see this arrow. It is rotating at the speed of 60 rotations per second. Now suppose we view this arrow with a series of short flashes at 60 times per second. Now each flash will illuminate the object at the same position in its rotational cycle. So in the second image you can see that the arrow has started appearing to be stationary. Now if we do it at 61 flashes per second, the arrow is illuminated at a slightly earlier part of its rotational cycle. This gives a perception of the arrow rotating backwards, as you can see in the third image. To understand the same for vocal folds, we need to understand the body cover theory concept. The cover is the pliable and the elastic part which moves over the body. Cover, being pliable, is formed of the epithelium and the superficial lamina propria. Now what is glottic cycle? When the vocal folds are adducted, the subglottic air pressure gets built up and reaches a threshold which opens the vocal folds. It starts opening at the lower lip and progresses to the upper lip. As the airflow happens with Bernoulli's principle, the vocal folds start to close again. Again, this happens first at the lower lip and then the upper lip. This is the glottic cycle. In slow motion, this is how it looks like. You can see first the lower lip followed by the upper lip. Now, vocal cord is the busiest muscle of our body, and it is impossible to visualize it with the naked eye. So we have two types of imagery for that, stroboscopy and high speed. What is the difference? Stroboscopy gives us an apparent slow motion, and it is a superimposition of multiple glottic cycles into a single image. Whereas high speed imaging is the true slow motion with only one single glottic cycle being visualized. The stroboscope equipment does not emit a continuous light. However, if we start giving a constant frequency, then only we'll see the vocal cord as a static image. Hence, the stroboscope gives a difference of 2 to 3 Hz in the flashes, which illuminates different phases of successive voice cycles, giving it an appearance of an apparent slow motion. As I have already said, stroboscopy is the gold standard for dysphonia, but it is specifically indicated when the hoarseness symptoms are out of proportion to the laryngoscopic examination. It also helps us to assess the depth of the lesion. We can also prognosticate the patient and tell the future chances of the complete voice recovery. Also in our practice, we have seen that stroboscopy post a conventional laryngoscopy has resulted in an altered and improved diagnosis in almost 30 to 40% of patients. This is how we perform nasal flexible stroboscopy. We can see there is a mic. The microphone picks up the frequency of the examinee's sustained voice, which triggers the stroboscopic light source. The camera is synchronous with the strobe light, so that whenever the light flashes, camera captures the image and we can get the stroboscopic video. How to perform the same in a patient? Can I have volume, please? First, the patient is told to phonate at their normal modal phonation to study the steady state vibration, followed by high pitch to see the vocal cords under tension. This is followed by a lowering of the pitch to understand the vocal mass effect over the vocal folds. And finally, we tell the patient to phonate loudly, which helps to test the relative stiffness of the vocal folds. A mild stiffness will be overcome by loudness. However, a very stiff cord, there will be no impact on increasing the loudness of phonation. We first record the fundamental frequency of the patient. As you can see, the stroboscope console showing the frequency of 166 Hz. It should be appropriate for the age and gender of the patient. If the frequency is higher than normal in males, we see this in pubophonia, whereas lower than normal in females is seen in androphonia. Now, it is very important to understand how to document and read the stroboscope. Various perception rating scales have been devised, the first given by Poborka in 1999, which was called the stroboscopy evaluation rating form. This has been further improvised and improved in the form of a voice vibratory assessment with laryngeal imaging called as VALI. There are various parameters that we need to understand and document the same properly. The first one being the free vocal fold edge. This is studied when the cords are at full abduction, being normal in this case. They can be convex in cases of Rinke's edema. They can be concave in cases of presbyophonia or a deep sulcus, or they can be irregular in cases of vocal fold polyps or cysts. Again, amplitude. It is the degree to which each vocal fold moves laterally. Here you can see how to document it pictorially. In a model phonation, approximately 1/2 to 2/3 of the width of the mid-membranous cord gets lateralized, which increases on increasing the loudness. This is the normal amplitude. The amplitude decreases in cases of reduced tissue pliability, like you can see in this case of a sulcus, and also if there is a vocal fold mass lesion, where you can see the left cord having a reduced amplitude as compared to the right vocal fold. Now, this is the most talked about phenomenon, the mucosal wave. Whenever the vocal folds oscillate, the superficial tissue, that is the cover, gets displaced in a wave-like motion. A mucosal wave can be well visualized going from below up and medial to lateral. This is the parameter which is reflective of the pliability of the superficial layer of the vocal folds. Here you can see a mucosal wave bilaterally, which is normal. However, in this case, you can see a wave which is going around the area of a localized abscess. This gives an appearance of a small boat bobbing on top of a traveling wave. This is a vocal cyst, which itself is not moving, but the mucosal waves around the cyst are normal. Whereas in this case, you can see a complete absence of the mucosal wave on the left vocal fold. This shows an infiltrative pathology of the vocal fold. Coming to vibratory behavior, this needs to be documented again. As you can see pictorially in the diagram, we have to mark the area, particular area, which is not moving and adynamic on stroboscopy. Any segment which is showing loss of mucosal activity, it suggests the underlying pathology being there. Another important parameter is the supraglottic activity. This is very important in cases such as muscle tension dysphonias, and it can be assessed in the form of an anterior-posterior contraction, like you can see here, or a lateral contraction, where the false vocal cords are trying to compensate for the primary pathology. Most of the times we see the vocal folds being at the same level. That is, the upper and the lower lips of the mucosal wave meet in the midline. However, this can vary again. There can be a vertical plane difference. As you can see in this stroboscopy video, the left vocal fold is at a slightly lower level. This is very vital to understand which medialization procedure you should choose for the patient, because a plain simple thyroplasty will not improve the vertical levels, but maybe using Gore-Tex or a fat injection will do. One of the most important criteria that helps us understand the hoarseness or the breathiness of the voice is the glottic closure. In the normal vocal folds, you can see there is no glottic gap. The vocal folds close completely. However, it can be an anterior gap in cases of a vocal fold scar or sulcus, posterior gap in cases of muscle tension dysphonias, and a symmetrical hourglass closure in cases of vocal nodules, a spindle-shaped gap again in cases of vocal fold atrophies in presbyophonias or sulcus vocalis. It can be irregular in cases of any vocal fold pathologies like polyps, cysts, etc., or an incomplete closure in cases of vocal fold palsies. Now, in a normal formation, the open phase predominates with being 50 to 60% in cases of males and 60 to 70% in females. What do I mean by this? whenever we take 10 frames or prepare a montage while the patient is phonating, if there are 10 frames, the 4 frames should be in contact, like you can see here. 3 phases should be in open phase and 3 frames should be in the closing phase. This varies in a lot of pathologies that we need to understand. We call it open phase predominance when more than 2/3 of the frames are in open phase, as you can see in this case of glottic incompetence, or a closed phase predominance, which is seen here. This closed phase predominance is usually seen in cases of adductor spasmodic dysphonias. Here you can see 9 out of 10 frames being in the closed phase. And this is how we document it. Last but not the least is the phase symmetry, where we see whether both the vocal folds are moving symmetrically or there is an asymmetrical motion associated. Like you can see here, the vocal fold motion being symmetrical, whereas here in the slow motion you can see that the right mucosal wave is excessive. This is the case of palsy, where there is loss of anchorage from the vocalis muscle and vocal ligament, giving a flappy or an excessive mucosal wave appearing for the right vocal fold. With this phase asymmetry, we have to check that sometimes one vocal cord is closing, the other is opening, or vice versa. They should happen together. Periodicity is again depending on the degree of hoarseness of the patient. It can be irregularly regular in cases of voice breaks. It can be regularly irregular in cases of tremors, and irregularly irregular in cases of complete aperiodicity, and the stroboscope will fail to track any motion. So to conclude, you can see all the parameters that we need to understand or document properly to perform a successful stroboscopy. Here are some of the lesions. These are vocal nodules giving a symmetrical appearance with an hourglass phonatory gap. Again, a long-standing polyp with secondary changes on the right vocal fold, giving a phonatory gap along with reduced mucosal waves on the right side. Now this is very interesting. You can see a cyst on the left vocal fold. However, the mucosal waves over the cyst are not diminished. This means the cyst is most likely lying superficial, and we can prognosticate the patient that there can be good results after the cyst removal. Finally, a video of sulcus, where you can see the sulcus arise, the mucosal wave arising lateral to the sulcus. There is reduced medial movement, but the mucosal waves are normal laterally. Every procedure has some drawbacks. So for stroboscopy, it is not the actual vibratory cycle, it is a superimposition of multiple glottic cycles. It highlights only the superior surface of the vocal folds, and sometimes it is not possible to visualize the lower lip properly. In severely aphonic or dysphonic patients, the strobe will not fire as there is no voice. And in patients of severe supraglottic compression, the imagery of the vocal fold is highly impaired and we cannot assess the pathology properly. These are my references. Thank you so much. Thank you to the organizing committee and organizers for giving me this opportunity. Thank you.